this lecture. So this is actually part of 2 lecture series this week and next week, hopefully at the same time. And the goal of this is actually to introduce survival analysis for the audience and actually to show them how to do actually some of those analyses using SPSS. So today we're going to just talk about methodologies and simple analysis comparing 2 curves. And hopefully next time we'll discuss more advanced modeling techniques using Cox regression. Now before we start, I'm trying to show you the differences, kind of a summary of statistical analysis done by type of variables or outcomes you have. So you can see here if you have a numeric outcome in the column, like a BMI or change in BMI or systolic blood pressure, HbA1c, and so on. Usually for summary statistics, we use mean, median, standard deviation, and so on. And in bivariate association, we use independent or PRT test, 1 by ANOVA, simple linear regression. And then for looking at simultaneous association with other variables, with multiple variables at the same time, we look at multiple linear regression. If your outcome is dichotomous, such as controlled blood sugar, yes or no, cardiovascular events, yes or no, pregnancy, yes or no, then basically you summarize your outcomes using proportions, odds ratios, relative risks, and simple analysis or bivariate analysis is by using chi-square or McNemar test if your data is fair, simple logistic regression, and of course multiple logistic regression for looking at multiple variables together in relation to the outcome. Now the third, what we're going to look at today is time to event. And time to events outcomes are very common in oncology studies, but also in other types of studies and so on. So you can look at time to death, time to disease progression, time to cardiovascular event, time to pregnancy, and so on. But here you can see that the actual outcome is made of 2 things. There's an event that we're looking to occur, and actually there's time to that event. So you'll see in the future that when we enter even our data in SPSS, our outcome will have 2 components. Now, today we're going to talk about how to summarize this type of outcomes using what we call Kaplan-Meier method. And usually we come up with what we call median survival time or median time for progression, and so on. And we can look at looking at 1 factor at a time and comparing these curves, Kaplan-Meier curves, by using the log rank test. And I'm going to talk a little bit about the assumptions behind those tests, and hopefully next time we'll talk more about Cox proportional hazard models, their assumption, and so on. So quickly to start, the dependent variable, as we said, is time to event. We'd also like to see what factors or augmentary variables affect that time to an event, such as age, gender, treatment, severity of the disease, and so on. However, we would like to note that there is no guarantee that you will observe that event in all the subjects of the study. And that could be due to a lot of different reasons. Now, what we call this is, we call it censoring in these kind of analysis. So basically, in censoring, the actual time until an event occurs is not observed. And the most common type of censoring you'll see in these studies are called what we call right censoring. And these right censoring might be due to the termination of the study and the person is still alive, or due to loss to follow-up, at which time that we don't know what happens to the patient after that time. So if you look at the picture, the graph below, you can see here I have 7 patients started the study at the same time. Some of them I can actually exactly know their time to event, time to till the event occurred. but a couple of them that has plus next to them, these people actually, I know up to that time they were alive, or the event did not happen up to that time. But at that time, either they were out of the study because we closed the study and they were still alive, or still the event did not occur, or like patient number 6, who actually got lost to follow-up at that time. So this is the last observation or the last visit in the clinic where that patient actually was alive. So you can also have different other types of censoring. And in those other types of censoring, you might have what we call a left sensor data and internal sensor data. Now, internal sensor data could happen where the event happens between 2 follow-up visits, but you don't know exactly when these two went exactly between, especially if the follow-up visits are far away from each other. So I'm actually analyzing a study, oncology study now, and they had a visit at, let's say, 3 months, and then the next visit was 6 months after that. So some of the patients actually progressed during that period, but they could not assess exactly at what time those people actually did progress. Was it actually after 1 month, 2 months from the last follow-up visit, or after 5 months from the last follow-up visit? And that could be problematic because that might actually bias your results by overestimating or underestimating a little bit your progression time. Left sensor data is that you know that the event happened before a specific time. Suppose you're looking at survival time, for example, for people with skin cancer. You might actually have people who actually come to the study who already have skin cancer. So we don't know the exact time of the occurrence of the disease. And that's why the occurrence happened actually before, sometimes. So we don't know the start time if you want. We might know the end time, but we don't know the start time. So these are very uncommon as compared to the right censoring. So, and they're more, if you want, more difficult to deal with in terms of analysis. So what we can assume for the rest of these lectures is that the only type of censoring we're going to deal with is actually right censoring. So let me tell you why these are difficult to deal with, censoring is difficult to deal with. Suppose this is actually you're looking here at a randomized trial where people are randomized to either surgery or medication. And in each study you have 5 patients. And you can see and then those randomized to actually arm A, there are 3 of them who had the events. These are the black arrows, and 2 who had censored events, so time to follow up, but no event occurred. And the other study, the other arm B, also you had 3 patients who had an event within the 30 years. And 2 of them also were censored. So if I'm going to look only at percentage of cardiovascular events, or what we call incidence proportion, then basically the percentages are the same, 3 out of 5 in both. So it looks like the 2 drugs are doing similar in terms of that. But this did not take any time into consideration. Some, even epidemiologists, might look at what we call incidence rate. So those incidence rate, for example, you count how many years each one was followed, and you add all these total number of years, and you count the events out of the total number of years. So in arm A, we have actually 3 events, and if I add all the years with the follow-up of all these patients, I have 90 per person year. So it's about 3.3 per 100 person year, and it's almost the same for the second group B. It is also still 3.5 per 100 person year. Now, again, these two types of analysis have some information in them, but they don't give the full picture. Some patients might ask different questions. Some patients might ask the following question: what is the probability that I live at least 20 years if I am on the medication? Okay. Now, and if I do surgery, how long do I expect to live? Now, these might be difficult because of the censoring here. I'll give you an example in a second. Is that, for example, if you look at arm A, when you look at 20 years, how do you count those who are censored? Are they surviving or not surviving? So these are the kind of things that we need to deal with this kind of analysis. So the prior analysis does not answer the above questions if you want accurately. And the analysis is not easy to the censoring of the outcomes of some patients. Any questions before I go on? All right, so now I'm gonna give you just a simple example just to show you the computation and everything. Suppose I have 30 newly diagnosed pancreatic cancer patients when we followed them for 1 year. And time to death in weeks were recorded and is given in this table below. So these actually, those 30 patients, all of them died within 1 week, within 1 year. And this type of data I can easily deal with. I can ask the question is that, what's the average time of survival? What's the median time of survival? We can compute the average, add the numbers, divide by 30. The median, actually, it's about 20.5. If somebody asks me what is the survival up to 26 weeks, so I can see up to 26 weeks, there's 12 more surviving, 18 dead, so I can compute a lot of things. So a lot of these analysis can be easily done. So if someone asks you what's the probability of surviving for half a year, 26 weeks, you can say 18 patients died at 26 weeks or before. The probability of death is 18 of 30. Probability of survival is 1 minus that. It's about 40%. If someone asks you what's the probability of surviving for more than 40 weeks, again, it's easy because we have events on everybody. We can compute the average survival time, which is 24.97. We can compute the standard error and confidence intervals. We can do median survival. And since it's continuous, we can do linear regression. Sometimes we might need to do a transformation because it's not perfectly, if you want, approximately normal. But we know, this kind of analysis, we know how to deal with it very easily because there's no censoring. Now, I'm gonna take the same data, but here I'm gonna think about there are few patients. You can see 1, 2, 3, 4 patients that are next to their survival time, there is actually a plus. And this plus indicates that this patient at that time, actually, most of these are lost to follow-up, since it happened before the end of the 1 year. So I had 4 patients who lost to follow-up. Now the question becomes, the same question is, if I want to look survival for 6 months or 26 weeks, how do I count this patient who has 15 plus and this patient who has 21 plus? So this is what becomes difficult. At 26 weeks, I had 16 patients die, and I had 2 patients who have censored before that. So how can I estimate the survival time, the percentage of survival? Now here where actually Kaplan-Meier came with this procedure, and it has very, very nice features, and we'll talk about this in a second. But it was actually based on a simple formula that says the probability of survival to the time t is actually what's the probability of surviving at time t given that you survived the actual week before. That is the probability of survival at the week before. So this is actually a simple probability that we teach usually in our, if you want, in our introductory probability courses. And then he applied it by using this second one. So he said the probability of survival at time t, given that you survived at time t minus 1, is 1 minus the number of death divided by the number of people at risk at time. This is what is important, because the denominator, when you say people at risk, if somebody has already censored, so they are not part of that at-risk group at that time. If they were censored before, so they are not at risk. But if they were not censored before, they are still counted in the denominator, what we call at risk. You'll see in a second. Times the probability of survival at time t minus 1. And basically, you start with the assumption that at time 0, everybody is surviving. So this is our example of our data. So here I'm trying to explain this. At time zero, the probability of survival is 100%. At 4 weeks, we had 1 death. So the probability of survival at that, or 1 minus number of death and number at risk, is 30. 1 minus 1 over 30, 0.967. You multiply it by the prior probability, you get 0.967. Now, again, at week 5, 1 died out of the remaining 29. So the denominator now is 29 because there's only 29 at risk. Because one of them died, so he's not at risk anymore. So 1 minus 1 death out of 29 is 0.966 times the prior probability of the week before, 0.967, you get 0.934, and so on. If you look here at week 8, we had 2 deaths from the remaining 26 on the study. So it's going to be 1 minus 2 out of 26. 0.923 times the prior probability is 0.8. Now we go to where we have censoring. So between 14 and 20, we had 1 patient censored at, I think, 15, if I'm not mistaken. So you can see after 14, there was 3 deaths out of 14, so the left should be 17 people. But at 15, 1 person was censored. So when we look at 20, we said there was 1 death out of 16 at risk at 20, not 17, because this should have been 17 if we did not have anybody lost to follow up. But there's one person lost to follow up. So at 20, we say it's 1 minus, there was 1 death at 20 divided by 16 remaining in the study or at risk. And then you multiply by the prior probability and then you get 0.551 and so on. I hope this is not too complicated, but the nice features of Kaplan-Meier are the following, is that first you can only calculate survival time at points where you observe events. So you don't calculate survival times if you don't observe any event at that time. So if people censored at 15, all of them are censored at 15, we don't calculate at 15 anything. And the nice idea is that we use censored data are accounted for in the computation prior to their time period, but not after that, since then they are not considered risk. So we use the maximum information on each subject until basically the time of censoring. And after the time censoring, we took them out of the study. So you maximize the use of your sample size. Some people might say, why don't we ignore the censored people, lost to follow-up? Because if you ignore the lost to follow-up, then basically your sample size decreases a lot, and then you don't have enough power to detect differences that you actually are set to detect. So that's why you can kind of maximize the use of the sample size that you have. Now, there are a few assumptions which are sometimes not easy to be met. But one of the assumptions is that censoring is not associated with the prognosis or the outcome itself. What we call is non-informative censoring. So censoring is not because those people actually only die. It could be any other reason they're not coming. And the other one is that the survival probabilities are independent from the time of recruitment. So whether you recruit somebody at the beginning of the study or after 1 month or something, their probability of survival is actually the same. So these are the assumptions under which we can compute all of these probabilities. Now, we would like to use SPSS actually to obtain the results. We're not going to do this by hand, of course. And this is just the same data I put in SPSS. Now you can see from here is that this is only the outcome that's made of 2 things. There is a time where there is time, what's called the survival time, and whether there is actually another outcome is 1 or 0, 1 is if the event actually was observed, and 0 if the event was not observed, which means censoring. So you can see most of them are in this case 1, but there is one of them that is 15, 0, that's a censored observation, 21, 0, and another censored, and so on. Now, you can go to Analyze Survival Kaplan-Meier in SPSS. You can see the outcome here is also made of 2 things. You have the survival time, and then we need to tell SPSS what's the status, what is actually observed. So, and everything else it will consider as censored. So when you click your valuable for observing the result, yes or no, you need to click on define and say 1 means I observed it. Anything else is basically you should consider censored. And then you click on continue, and then if you want the graphs under the option, you can get the what we call a Kaplan-Meier graph. You need to do the survival graph and click continue, and this is what you get first. So this is the output that we get, and this is exactly what we actually computed at time 4. The estimate of survival was 0.967. So at 4 weeks, this is actually the probability of surviving for 4 weeks is 96.7%. The probability of surviving, let's say, for 20 weeks is 53.1%. The probability of surviving for 40 weeks is 30.4%, and so on. Not only it gives us these estimates, but also it gives us the standard errors. So which basically it will allow us to construct confidence intervals for those survival probabilities. Basically, you can take the estimate plus minus 2 times the standard error as a quick way to do that. It also gives you a small table where it tells you what's the percentage of actually censored data you have among all your observations. So here I have 30 observations, 26 were events where I observed death, and 4 were censored. So, couple of notes. The accuracy of the estimates of the probability of survival actually goes down with time. If I go back and I'll show you the standard errors, you can see that these standard errors are going up. So this means that you have more variability. Now it reaches a point where basically it starts going down. Now, although it's going down, but you can see also the probabilities are smaller. So relative to these probabilities, these numbers are still very big, because they are based at the end based on remaining 6, 5, or 3, or 2 patients in the study. So remember, these probabilities are based on very few patients at the end. And that's why when you look at the tail of the probability, the tail of the survival curves, you have to think very carefully about how to interpret the tails of these survival curves. I'll show you a picture and we'll discuss a little bit about those tails. Again, as I mentioned before, it's better to construct and interpret the 95% confidence interval of the survival probability estimates. So you can use the estimate plus minus 2 times the standard error. The other thing the computer will generate also for you something called the mean and the median survival times, along with their confidence intervals. And this is the Kaplan-Meier curve that it shows you. Now these are very common outputs that we use. Now we don't use a lot the mean survival time. We use more what we call the median survival time. But this definition of the mean and the median are not the same as the mean and the median we use for any numeric variable. For numeric variable we use the mean is basically add the numbers, divide by 30 in this case. The median would be the middle number. There's some 50% are above that median, 50% is below that number, but that's not the case here. These are more graphically obtained. The mean is basically the area under this curve. So of course, the more this curve goes to the right, the bigger the mean, which means there's more survival, the people are surviving more, and basically there's bigger average survival or mean survival time. But what's more frequently you'll see in publications is more the median survival time, and for that the median survival time is defined by the time by which 50% of the people have already died, and the probability of survival is 50%. So median, so there's 50% who are already dead and 50% remain in the study. So that's actually the median survival. You can graphically see it on the graph. Now the graph also will be used for other things. Like if I want to compute what's the survival at 30 weeks, so I can go up from 30 times 30, go up, and then go to the left and see what is the survival at 30 weeks. So we can actually compute those if they are not part of actually our table. Anyway, questions before I continue? Okay. Now, so as we said, the regular definition of the median and mean are not applied in this situation. This is an example, another example just to show you. This is a recent actually study in the New England Journal of Medicine. It's a randomized trial of high flow oxygen therapy in infants with bronchiolitis. In this multi-center randomized control trial, we assigned infants younger than 12 months of age who had bronchiolitis and a need of supplemental oxygen therapy to receive either high flow oxygen therapy or standard. Infants in the standard therapy group could receive rescue high flow oxygen therapy if their condition met the criteria of treatment failure and so on. So this is the methods of the study, and basically this is one of the outcomes they look at is the proportion remaining free from treatment failure in the two groups. And you can see here in the two groups, and this depends on the date. Now those actually patients, you can see also now it's very customary to add to the Kaplan-Meier the number of people who are at risk who are remaining in the study. Okay, so you can see they started by equal numbers due to randomization. That's a large sample, about 1,500 people. By day 2, most of those patients are out of the study. And then they continue. And you can see that it looks from this study that those with high flow oxygen therapy are having higher proportion free from treatment as compared to the standard oxygen therapy. And then they compared the two survival curves using something called the log rank test, which I'll talk about in a second. Should we always have a median survival? I mean, if you look at this picture, I just created this picture. If I ask you to do the median survival from this graph, you'll see that if I go 50% here, I go 50% to the right, I don't even touch the graph. And if I ask SPSS to do this for me, you can see under median survival it gives no estimates at all. So it is possible that we actually don't have a median survival. Actually, the first time this happened to me is when I was doing an analysis for a database of 1 million breast cancer, women with breast cancer survival time for them. And these were over 20 years. And I couldn't find that. And then when I looked at the graph, I understand why I couldn't find this. So why do you think we couldn't find the survival time? Anybody else?
More than 50% of the patients survive.
Think about it.
Survive 30 weeks. Because more than 50%
Any guesses?
more than 50% of subjects survive.
Sorry, I'm just gonna raise the volume here. Sorry, go ahead.
Yeah, because more than 50% of patients survived the duration of the study.
So the survival rate is very high in this study. So the survival rate is very high. That's why by the end of the study, there's still more than 50% of those actually patients still surviving. According to this, what would be the probability of surviving about 5 years. So again, we can use the Kaplan-Meier curve to get 5-year survival probabilities, 10-year, 20-year survival probabilities. So for 5-year survival probabilities, in order to get that, we take 5 years from down, we go up, and we estimate that number. And actually that number is about 90.9%. We can also look at, let's say, 20 years survival. So at 20 years survival, we can go up here, and we can see it is about maybe 70 something, so it's 75.8. Now, when you see these horizontal lines, now this means during that time, we did not observe any event. There might be a lot of people who are censored. You can see all these pluses. These are censored observations. But we did not see, for the people who stayed in the study, we did not see any event. Now, if I want to talk a little bit about here, the end of the study. So I'm going to go back, just a few slides back here. I want to talk a little bit at the end of those tail graphs. Now here you can see at the end, it goes to 0, which basically means that at the end of the study, the last patient died. So we observed the last patient who died in the study. Now sometimes they will not go up to 0. This means usually it's the last patient that in the study is still alive and got censored in the study. So here you need to think about the effect, because now here the effect of one patient is very high. So if there is a very long, steep decline, you have to worry about that, because that is actually probably is the one patient at the end of the study that making that long, steep decline. And you need to think about how much is that interpretation of at time 50 everybody dies or not, because it's basically one patient toward the end. So we'll talk more about this. Let me go to comparing actually two graphs. So after looking at these different situations, we want to look at comparing two survival curves. And in this case, suppose the same data we have, but we know the treatments from where these people actually took, what treatment these two people took, the 30 people. So we can actually draw the Kaplan-Meier curves to look visually into the data. And in this case, we just added the treatment allocation for each of the patients. And we did the same thing. We went to survival, the Kaplan-Meier, but in this case we added the factor. And we asked SPSS to compare the factor. And now the graph looks, you can see now there are two survival curves, and these are by treatments. Now according to these survival curves, we can try to guess which treatment is better. So in this situation, for example, the green one, treatment number 2, looks much better than treatment number 1, because at any time, if you take, let's say time 10 weeks, there's about only 50% surviving at treatment 1, but at treatment 2, there's probably still about 90% surviving. And the same, which at 20 weeks, here about less than 20%, versus about maybe 75 or more percentage surviving here. We can estimate from this the median survival curves for both. So the median survival curve for treatment 1 is about 8 or 9 or 10 maybe, and the median survival curve time for the second would be around 40 here. So SPSS will actually produce this for you, and you can see here that the estimate for treatment 1 is about 8 weeks, treatment 2 is 20 weeks, the overall is about 14, and you can get the confidence intervals. Now the question that remains is that observed difference statistically significant or not? And that's actually what the Kaplan-Meier does. So the Kaplan-Meier is one of the different methods to compare survival curves, where basically you're saying, are these two survival curves the same or are they different? This test does not depend on the distribution of the survival curves. In other words, if you have outliers in your data or you don't have outliers, it actually depends on ranking of those observations. So this makes it a bit robust to a lot of different types of survival curves that might occur. And SPSS, so we call it usually a parametric test. It's probably the most used one in survival curves. Although when in SPSS can provide for you another test, the Breslow test or the Teron-Ware test. Now the Breslow test is different than the log-rank test. It basically gives a little bit more weight for early events. So if you see the events early, it gives them more weight in terms of the computation. Versus the log-rank test assumes all these events are uniform over time. So are equally likely to occur at any time period. So that's basically the difference between them. And you can see here, the log-rank test, some people call the Mantel-Cox test, has a p-value of at the end 0.05000. And this means that there was actually a significant difference. That what we observed in the graph is a true significant difference between the two groups. Now, this is another example. Now, if you look at this study, these are two treatments that have almost the same median survival time, which is about 18 and 19 years. But you can see that after that, we have a difference in terms of survivals, and before that we have difference. So before these 18 or 19 years, it looked like treatment 2 is doing much better than treatment 1. But then after this, and crisscross where the two distribution cross, it looks at people who survive up to that time, they are doing much better than people who on treatment 1 than treatment 2. Now, the log-rank test cannot capture that. So it's looking overall, are these two curves similar or not similar? And you can see that the p-value for this is about 0.3, which says the two distributions, survival distributions here, are very similar to each other. Any questions about this? I want to open this more for discussion from you guys to see if there's anything you don't understand about those, or you want more clarification of those, and then we can actually next time talk about Cox regression, multiple Cox regression. So this is the basic analysis that you would do for a clinical trial comparing two groups. Or if you want, this is the basic analysis also for even an observational trial comparing two groups. Now this is the most common thing you'll see in the publications. And the graphs, and sometimes these graphs, instead of graphing the survival, you might actually graph the hazard over time. So the hazard over time will start from 0, and then at time 0 there is 0 hazard, and then at time increases, the hazard increases. So it depends of what's the choice that the authors would like to present. Any specific questions about this?
No questions.
Anybody who worked with survival analysis data? Or time to event in general?
No one, no.
Excuse me?
None of the attendees worked on survival.
Okay. So I think I want to stop here. I don't want to introduce the Cox regression models right now. I want just to see if all these features of of the basic survival analysis are understood. And I mean, the important parts that you need to think about is that how is the data collected, and especially from my experience with those types of studies is that the follow-up has to be, if you want, the time to follow up is very adjacent to each other. So you shouldn't have follow-ups long, very long follow-ups, unless you know that survival is very long. I've done a lot of analysis for if you want very severe cancers, and usually the follow-ups are every other week or every other month maximum, because you want to capture the exact time of progression of the disease or exact time of survival of disease. And if you wait longer enough, then too long, then you might have biased these numbers. So if my follow-up is every 6 months, that actually, and the overall probably survival of those patients is about, let's say, a year, then I'm probably overestimating a lot my survival time. Now, you can think in your domain, it's not necessarily you only need to think about this is only applied to oncology. We've done studies in social sciences where we look at time from marriage to first pregnancy. We looked at cardiovascular events, time to first cardiovascular event, time to recurring MI. I mean, this can be actually done for a lot of different types of, if you want, specialties. So, it's becoming, the application of those are becoming easier and easier with different software that can do that. Now, this Kaplan-Meier here, all it does is actually, it is dealing with right censoring. For less censored data or interval censored data, the situation is not actually as easy as here. And there's a lot of assumptions that you have to even go with before doing that. All right, I think I'm going to stop here. And I'd be happy to answer any questions if you want.
Ziad, can you hear me? Ziad, can you hear me? This is Ghaida.
Yes, I can hear you.
Okay, thank you so much. There are several people sitting here who are interested in conducting survival methods. None of us have done it so far. And I think it's very important to grasp the concept through application. I understand from what you discussed earlier that there will be applications next week, right?
Sorry, but I think you are cutting off.
Okay, can you hear me now?
Yes.
Okay, so let me repeat. I said all of us here have not done survival methods analyses, but are interested in applying them. And next week you're going to be showing hands-on exercises, right?
I'm sorry, but you are cutting off. I'm getting the first few words and then it's gone.
Do you want us to shut down the video and just leave the audio on? Maybe
Yes, I can shut down my video.
Okay.
If you want, no problem. Let me just do that. All right, maybe now?
Okay, I'm going to give it a last shot. If it doesn't work, we'll shoot you an email.
All right.
Okay, we are all interested in applying hands-on survival methods analyses, and I understand you're going to do that next week, part of the exercises.
Yes.
Okay.
Part of the exercise. We can give some exercises, and if people have SPSS with them, they can follow together.
Okay, so the question is, do you want to send something between now and next week that we can try to dabble with, and then we may have questions next week?
I can send probably something by Sunday. By Monday.
Something easy basically, just covering the concepts you covered today so we know we understood them as opposed to just listening to them.
Yes, sure. We'll do that. We'll do some questions and some data
Perfect.
and some application. That should be good. Yes.
Perfect, because I think we've heard survival methods lecture several times, but I think the step to do them is a different story.
Yes, for sure.
Perfect.
For sure. We'll do that.
Okay, thank you.
All right. Great.
Anybody? No? All set?
All right.
Okay.
Okay,
Any-
so no more questions, doctor.
Okay. Thank you everybody for
Thank you.
showing up.
Thank you.
And next time, the topic next week we'll do more application about 10-15 minutes. And then I would like to introduce Cox proportional hazard models for you. It's basically, and these are very important for observational studies where you need to adjust for imbalances between groups because they are not randomized. And for example, look at survival curves in 2 treatments, but adjust for the age of the patients, adjust for any genetic mutation, adjust for gender, severity of the disease, family history. So how to build a model using Cox proportional hazard model and what are the assumptions also behind that and how we can deal with these outputs.
Okay,
Great, thank you so much.
thank you.
All right, thank you everybody. Thank you.